Good morning, my name's Anna. I'm the head of the Internal Medicine Department at Davies Veterinary Specialists. And this is Catherine, one of the senior medics on the internal medicine team, but also our infection control lead here at Davies. So today we're going to be talking a little bit about Brucella, because there's been quite a lot of hype in the veterinary press about Brucella, and I just wanted to find out a little bit more from Catherine about Brucella and what we should be doing about it. So Catherine, how common is Brucella in the UK, and are we only seeing it in travelled animals? What's the current situation?
So at the moment, Brucella is uncommon in the United Kingdom, although because we are seeing increasing imported dogs from certain parts of the world, we are seeing more and more of it. So certainly our experience at Davies is that we've only ever diagnosed it in dogs that have travelled or have been actually imported rather than ones that have been on holiday and then come back to the UK. But it is obviously a contagious disease, and if we have high enough numbers in the UK, I think at some point we will see it in untravelled dogs, but that is not currently the case.
Okay, and what are the clinical signs of Brucella then in a dog?
So variable from none at all, and this is the population I think that we potentially are most worried about, because they can come in and be contagious and potentially zoonotic to you and show no clinical signs at all. And then there are the population that are clinically affected by brucellosis, and they can come in with a variable selection of clinical signs, from pyrexia of unknown origin to things like discospondylitis, so spinal pain, polyarthritis, kind of vague clinical signs like an abdominal lymphadenopathy, things like that. So it can be very variable clinical manifestation.
Okay, no, that's fine. You mentioned about it being zoonotic, so can it kill people? What are the concerns for us as vets?
So I think probably the concern for us as clinicians day to day, seeing these patients, say for example for a physical exam and a routine vaccination, I think that is very low. There are certain settings where we would have a much higher risk of getting the disease. So for example, if we were to see a bitch after whelping and she had a vaginal discharge, or she was aborting, or a male dog with a preputial discharge, something like that, those fluids are much more contagious to us. Similarly, if you have a male or female entire dog and obviously the urinary tract can contaminate the urine, then that can also be a risk.
Okay.
When we're doing our diagnostics, if we're taking things like cerebral spinal fluid samples or joint fluids, then those are also high risk fluids to handle. But I think our risk is low if we are sensible about it, but it is a zoonotic disease, and it does have the potential to be quite serious zoonotic disease in us and cause kind of long-term illness and very significant clinical signs, and it can result in people needing to be hospitalised if they get bad disease.
Okay, that's quite worrying, but I guess if I was just doing a blood sample, would be minimal risk, and as long as I wear appropriate PPE, then
absolutely. So although brucellosis can have a kind of a bacteremic phase where it's circulating, again, you know, unless you are really exercising not very good hand hygiene, then you know your risk of doing things like that is very low indeed.
Okay. So which dogs should I be testing? Because obviously if a dog's come in recently and has clinical signs consistent with Brucella, and you know, you have a clinical suspicion, then that's a clear indication to test. But are there other situations you might want to test these dogs, and how would I go about testing them in terms of what test do I need, what do I need to wear as a clinician, that sort of thing?
So the way we do it at Davies, I'm not necessarily saying this is the right way of doing it, because I think it's a situation which is evolving all the time, but we would screen dogs from certain parts of the world. So Eastern Europe is a hotspot, so places like Romania, but then basically it's nearly endemic nearly everywhere in the world, and trying to identify prevalence data from different parts of the world is very, very hard indeed. So it can be tricky to know whether or not we should be screening all travelled dogs or just from certain parts of the world. So we have a red list of countries, and Romania and kind of Eastern Europe are on that list. And we screen those dogs if they're coming into the hospital for procedures, whether they have clinical signs or not. And we use a patient-side test for that, and we'll talk a little bit more about that in a second. But I think in terms of kind of dogs that are symptomatic, then before we do anything, we should be obviously testing them before we do any kind of diagnostic procedures. I think for vets in practice, for me, the most worrying thing that vets in practice could do would be neutering these dogs that are coming in from Eastern Europe. They're potentially then handling, you know, reproductive organs which potentially have the highest degree of infectivity. So those are the dogs I think that kind of first opinion practitioners should be proactively screening regardless of clinical signs.
Okay. And if we're proactively screening them, do we need to just wear gloves? Do we need to wear full PPE? Do we need to consider visors? Sort of how much protection what do we need to do?
So I think, again, it's hospital dependent, but certainly from my interactions with Public Health England, so we've had a couple of cases here, and then obviously it's a reportable disease, and so then you end up getting government authorities involved. If you are wearing full PPE, and what that is kind of loop gown, gloves, ideally some kind of face shield as well. You don't have to wear a mask if you're wearing a full face shield or a mask and goggles. Then Public Health England think that your risk is negligible and no further action will be taken. So if when you're taking that blood sample you just don that PPE, it saves the paperwork, frankly, later on down the line. If you, from a logistics point of view and a safety point of view, if you were to wear gloves alone, then I think actually your risk would be very minimal. But I think if we wanted to be absolutely belts and braces and proper about this, we should be wearing PPE while we're taking the samples.
Okay. So you've mentioned if we get a positive test that it's reportable. But actually, practically, if you do get a positive test, what do you need to do with that patient? If they're asymptomatic versus if they're symptomatic, are there treatment options and so on? What do we do with these group of patients?
So the first thing is we need to determine what test is positive. So for example, at Davies, we have in-house serology tests. So they're just like a COVID test, they're kind of lateral flow, and they are basic. Is it positive, yes or no? And if that is positive, I would always confirm that at an external lab. So there are two different labs tests at the APHA lab that we use in combination, the SAT, which is the slide agglutination test, and then the ELISA. And together, when they're run side by side, it improves the sensitivity. So if you have an in-house positive test, I would put that patient in a slight holding pattern if it was safe to do so, while we get confirmatory tests from a more reliable source. If it's not safe to do so, and you have to hospitalise that patient, which is, so we have been in that situation here, we do the minimum workup we can. Two reasons. One is that we don't want to expose staff to potential infection, but also because most labs in the UK will not handle samples. So you can do your diagnostics and take your samples, but then you don't really know what to do with them. If you have a positive APHA test, either ELISA or SAT, the APHA are actually very happy to help with these cases, help interpret the results. So if you are struggling to understand them and want to know whether or not this is a genuine infection, they're very good to give you advice. Then it becomes a conversation we need to have with the owner. There is no obligation to put these pets to sleep, despite what is reported sometimes in the media. It's a discussion between the owner and the attending vet. However, as you know, Brucella is very challenging to treat. It involves kind of triple antibiotic therapy. You treat them for as long as it takes for them to become seronegative, but that may never happen. And even if they do become seronegative, we would still class them as lifelong carriers. And that has welfare issues for the dog, because they still are at risk of developing things like discus spondylitis and all those diseases that we spoke about if they don't obviously have them already, if they're asymptomatic carriers. And they do pose a risk to the people cohabiting with those dogs, to the family, to vets, to groomers, etc., but also to the canine population in the UK. And we do not want this disease to become an endemic concern. So certainly the cases we've had here, both have ended up being euthanized, but that is because they both had clinical disease rather than because of the other things that we've just discussed. But I think it's just a case of a very frank conversation with the owner.
I think the most difficult population of dogs are those that, if you've got a dog that's symptomatic, it's really poorly with Brucella, it makes the decision-making process, it's still challenging for the owner, but it is you have a sick dog, and if we're discussing euthanasia, it's a little bit easier. But it's that asymptomatic group of patients where you've identified Brucella incidentally. What do you do in that circumstance? Particularly if they've been imported 4 or 5 years ago and they're well. Those conversations can be very, very challenging. But ultimately, we just have to be really frank and open and assess the risk and discuss it with the owner. As you say, there's no, even though it's a reportable disease, it's a little bit misleading in that I think there's this kind of a feeling that you have to put these patients to sleep. And whilst actually that is real, and we often do recommend that, it's not obligatory.
No, not at all. No.
So if we do decide to treat either in an asymptomatic seropositive patient or in a patient that's unwell. What's the long-term prognosis? You mentioned that can they just be asymptomatic for life, or do they all develop clinical signs?
It's really, really variable. Some of them can remain asymptomatic for the rest of their life and go on to die of completely in another disease. Some of them can develop subsequent clinical signs, so it's really, really variable. Occasionally, they can clear the bacteria, but it's very hard because obviously we treat them until they're seronegative. How do you know whether or not they still have brucellosis or not? And you'd have to follow them for years doing repeated serology to see whether they become seropositive again. So it's very challenging. I think the diagnostic tools we have available are still quite limited for this disease, but I suspect that will change in the near future because it is a worldwide problem.
Yeah. So just to kind of conclude, what's your advice for a vet in general practice, perhaps somebody involved in running the practice, in terms of creating some sort of protocol? Is it something that we should be recommending all practices do have a protocol around Brucella, or what do you recommend for vets in practice?
So I think it is really important to have it on our radar. And I think even if you don't proactively test patients, if they have travelled from certain parts of the world, we really need to have Brucella on our list, very high up on our list. I don't think it's the wrong thing to do to have a screening test in situ, and then you can just do it. Certainly, like I said, if you're vaccinating, doing a physical exam in the consult room, really the risk of getting brucellosis in that situation is very, very slim indeed. If you wanted to be complete, you could put a visor and some gloves on, and then at least there's any kind of saliva spray, or when you're handling around the mouth or anything, you're protected. My personal feeling is that prior to neutering this at-risk population, we should be testing them, either externally or using an in-house result. So I think it depends on the situation, but I do think it's something that we all need to be very aware of, because you don't want to miss it.
No, exactly.
And then realise after neutering or after doing a cesarean or something that actually that dog had brucellosis, because then you've really exposed yourself. Yeah.
No, that is quite concerning. And I think the other thing that's concerning is that actually we don't always know when dogs have been imported.
Very true.
Because there is an illegal puppy trade, and some of these dogs are probably coming in and we don't even know about it. So it has to be on our radar, even in dogs that haven't travelled, because I guess in those kind of rescue dogs or whatever, that owners have thought that they've done a really good job here, actually there are situations that we unexpectedly may see Brucella in the future. So super, that's been really interesting. Thank you very much, Catherine.
No worries at all.
And if anyone has any questions, then obviously get in contact with us, we'd be happy to help. Thank you.